Hey, hey everybody, welcome. It's great to see folks, especially on this warm day. I guess we went from spring to summer pretty quickly here. We're just kind of waiting as everybody pops in. And you're welcome to turn on your video too. We'd love to see you, see who's here. Um, and we'll get started in just in the next minute. Libby, do you want to just provide some information about the CMEs and the disclosures? And then I'll introduce Dr. Higgins, our guest today.
Absolutely. So I'm just going to share my screen. And I will also share this in the meeting chat. But if you would like to claim continuing education credits, you can use this code here. I'm also going to share our disclaimer, standard disclaimer, that views expressed by audience members or learners do not necessarily reflect those of MaineHealth. And Dora, take it away.
Great. Thank you so much. And again, Libby's going to post in the chat the information for CMEs. So we are, and also just want to mention Dr. Higgins will be presenting. If you have questions, feel free to put those in the chat and he may answer them as he goes along or at the end of his presentation. And also after he finishes, please feel free to unmute and ask a question too. And please note that this is being recorded for podcasts too. For both the audio visual is being recorded as well as the audio for podcast. So we will be rereading the questions that come up in the chat before answering them. And please, we'd really love to have you also interact and unmute and ask questions too. And it makes it easier for people to listen to as well. So I'm just thrilled to have Dr. Higgins with us today. David Higgins is a double board certified pediatrician and preventive medicine specialist. He's an assistant professor of pediatrics at the University of Colorado School of Medicine, and he sees patients on a regular basis as an attending physician at the Child Health Clinic at Children's Hospital in Colorado. And he brings really a distinctive combination of clinical experience, having practiced in both urban and rural settings in Colorado and Montana, alongside really serious research chops. So his scholarship focuses on vaccine delivery, communication strategies, and what he calls the science of vaccine confidence. He's published in some of our field's most prestigious journals, including the New England Journal of Medicine, the American Journal of Public Health and Pediatrics, often alongside his collaborator, Dr. Sean O'Leary. A recurring theme in his work is puncturing misconceptions about vaccines, vaccine hesitancy in particular. He's also a board member of Immunize Colorado and has been recognized with the Emerging Leader Award from the Colorado Public Health Association. So, at a moment when Maine, like the rest of the country, is navigating real challenges around vaccine confidence, Dr. Higgins really brings to us both the research and the practical, clinical, pragmatic perspective that we need. So please join me in welcoming. And Dr. David Higgins, I usually say welcome to Maine. You're here virtually with us. So thank you so much for spending your time. I know you're extremely busy and we're just honored to have you with us today. So thank you. And I'm going to pass the baton over to you, Dr. Higgins.
Great. Well, thank you so much, Dora. And unfortunately, I'm virtual because I would love to have your weather today. We went backward. Instead of going into summer with schools ending here, we're back to 40s and sleet. So I am really excited to be with all of you today and talk about this topic that is obviously front and center for many of you, whether you're a clinician, whether you're a public health professional. You are dealing with this every single day. And what I want to do in the next 60 minutes is I wish in 60 minutes we could solve the problem of low vaccine uptake and leave time for questions and answers. But we're not going to be able to do that. So what I really want to do is give you some practical tips and tools to address hesitancy about vaccines. And I'm going to start first by just saying I have nothing to disclose other than I will say I think vaccines are one of humanity's greatest achievements. If that makes me biased, then so be it. So here's the objectives for today. First, I really want to just briefly describe the current landscape of vaccine-preventable disease and explain how federal policy shifts have kind of changed the picture. Now, I'm not going to go into a lot of detail on this because I know that most of you on this call and watching today are well experienced in this. You're living this day to day. What I really want to get into is evidence-based communication strategies, not only for individual conversations that you may be having with patients, clients, families, but also communities. And I want to zoom in a little bit, especially for you in Maine, on religious communities and communities that may not be a part of some of your school and child care vaccine requirements. And then finally, like I said, I want to zoom out to the community level and not only talk about individual face-to-face communication about vaccines, but also how do you do it effectively at the level of a community. But we need to start with why this moment matters. We're going to talk a little bit about the return of vaccine-preventable diseases, disruptions to vaccine governance at the federal level, and then this low-trust environment that we are all operating in. So if I was with you in person, I'd have you raise your hands and tell me how effective is the influenza vaccine that's in these vials right here. And when I give this talk and I'm in person, I get a lot of smart people who say, well, it depends on how well it's matched with the strain that's going around, somewhere between 30 in a bad year and 60% effective. The answer is 0. When the vaccine's sitting in these vials, it's 0% effective. And you all know this, right? There's this mantra that we talk about in the vaccine delivery world that vaccines alone don't save lives, vaccination saves lives. The most incredible vaccine can be created. And if nobody accepts it, it doesn't do anything. So vaccine-preventable diseases are back. I have yet to see and treat a case of measles in my career. And I've now been very close and had patients that could have come in and seen me in my community and ended up seeing somebody else in the emergency room. But measles is back. So this is a map of measles cases among residents in 2024. And as you can see, there were cases scattered across the United States. Here's 2025. We are just getting deeper and deeper blue here on this map, spread across the United States, of measles cases that are occurring in our country. If you look over time at the epidemiologic curve, what you see is that since the late 1990s, we have had sporadic years where there have been large outbreaks. And most of those have been due to a single large outbreak. Well, 2025 and now 2026, we're seeing larger numbers of measles cases and multiple outbreaks, more than we have in several decades. In 2026, we're already up to over 1,800 cases. We are easily going to eclipse 2025 numbers for measles. So why does this matter? Well, measles is a unique infectious disease. The R naught for measles, that's the number of cases that will occur from one person who's infected mixing with a community that's vulnerable. The R naught is 12 to 18. This is the highest of any vaccine preventable disease. What that means is that in order to protect a community, you have to have a high level of vaccination. We are fortunate that the measles vaccine is incredibly effective. We have some vaccines that are not as effective, but measles vaccine is incredibly effective. And if you get the community vaccination rate up to that 95%, you can actually stop the outbreak in that community. We frequently hear about vaccination rates at the national, state, and sometimes county level, but the reality that you're all living and understand is that measles outbreaks happen at the hyperlocal level. So even if your state has a good vaccination rate, if you have a town, a religious or cultural community that has a very low vaccination rate, they are primed for a serious outbreak if measles comes into that community. The other reason that measles matters is that it's kind of the canary in the coal mine, okay? This is one of the first diseases to return when vaccine coverage begins to erode because of how contagious it is. So it's important. It's important to follow. Now, I'm also not going to belabor this point because I could do a whole talk on what's happened over the past year. This is a nice timeline put together by the MaineHealth Coalition, who's doing some fantastic work in this space. And I've been fortunate to collaborate with them on some of this. But this is just a nice, simple timeline to remind you all of the things that have happened in the past year. Okay, so the entire Advisory Committee on Immunization Practices, the ACIP, was fired and reappointed almost overnight with new members, many of whom a federal judge has said were unqualified to serve in that role. And that ACIP voted to remove thimerosal from flu vaccines. They changed several recommendations, including recommendations for the MMR vaccine and for COVID-19 vaccines, in addition to the hepatitis B vaccine series and the birth dose in particular in December of last year. And then bypassing the ACIP altogether, the CDC really at the discretion of HHS leadership revised the childhood immunization schedule, completely bypassed the normal processes, and created a tiered schedule, right, with kind of normal risk, high risk, and shared clinical decision-making recommendations. Well, in March, a federal judge blocked the changes that occurred to vaccine schedules. And I wish that was the end of the story, but it's not. That case is ongoing, and I am not a legal scholar. I will leave that to some of the other fantastic legal scholars that I collaborate with. But that case is not done. And efforts to solidify these changes are also not done. As we saw, the CDC published a new ACIP charter last month, which has since been removed, I believe, as of yesterday, but the saga will continue. I don't have any doubt about that. So what you've seen is professional societies stepping in to fill that gap. And really, the American Academy of Pediatrics led the way in that. The AAP has been making vaccine recommendations since the 1930s, so this is not new. But in this case, they have had to step in and fill the void left by the disruption in leadership. And other organizations have come alongside, including the American Academy of Family Physicians and many others that I didn't list on this slide, have come alongside and said we endorse or support these recommendations. But here's the reality of what we're living in. So this is a figure from Kaiser Family Foundation, KFF, who has done some incredible polling over the past several years on trust and confidence in vaccines and in those that recommend them. And what they have found is that since the start of the pandemic in March of 2020, you have seen a slow and steady decline in trust in the CDC and in federal health agencies regarding vaccines. And that decline has been, we have seen this among both people who identify as Democrats and Republicans. This is true across the political and ideological spectrum. As you can see, the shifts change depending on who the federal administration is. But we are operating in a low trust environment, at least at the level of our institutions. Okay, I'm going to pause there briefly. So the next thing I want to talk about is the vaccine information ecosystem. Now, I want to talk about this because I really want to emphasize what your communities, what parents, and what your neighbors are seeing every day. I run into many public health professionals and well-meaning physicians and clinicians who don't always understand just what the people that they interact with every day are really exposed to. So we're going to start by playing a game. Okay, the game is 1800s or 2026. So this quote is either from the 1800s or 2026. Vaccination has caused more deaths since its introduction than those caused by war or famine. That's from the 1800s. Okay, the next quote. Vaccination is a method of mass destruction, a method of depopulation. That one is from 2026. The facts, though often suppressed by pro-vaccine activists, have always been accessible to the people who are willing to question them. That's 2026. Vaccination provides no protection. When exposed to infection, people suffer just as much as others. That, in fact, is from the 1800s. And one final one. Vaccine activists are afraid of the search after truth. They fear uncovering errors. That's from the 1800s. So what is my point here? Well, this is my point. Vaccine hesitancy and many of the messages that you or your communities see online or spread through their networks right now are not new. They have been around as long as vaccines themselves. This is a picture of a physician administering the cowpox vaccine in 1802. And if you look carefully at the picture, you will notice that people are growing cows out of their body. This is one of the first examples of kind of this concern about vaccines. There's a famous picture called Death the Vaccinator, published by the London Society for the Abolition of Compulsory Vaccination in the late 1800s, picturing the physician or a clinician here delivering a vaccine and painting them really as being this bringer of death, right? There's this emotional appeal even then. And I love these postcards as an example. So these are postcards from 1896 that were handed out by the National Anti-Vaccination League in the UK. These postcards could absolutely be a social media post in 2026. Do your own thinking. Search what is truth. Who is profiting from vaccines, right? These messages are coming out in social media in 2026. In fact, for my Substack several weeks ago, I created a fake social media post that I intentionally put that this is a historical recreation and not real because I don't actually want it spreading around, with these ideas to show this is what we're seeing today. These messages are not different. Okay, but what is different? Well, there are several really important things. So back in the 1800s, with the same messages, the reach was a town. People had to bring pamphlets and hand them out in a town. The speed of that took weeks to months. Right now, a post can reach the entire world in seconds. In that time, there was more accountability. Today, you don't even know if that post is from a human being or from AI. There was also more of a shared reality in that time. People in towns and communities and neighborhoods had a more shared reality about everything that they went through in life. Now, everyone lives in their custom algorithm. Their reality is really determined by the algorithms that feed them information. The amplification of language that's optimized for outrage is incredibly more prescient today than it was in the past. And the institutions that were referees for some of this, including things like the CDC, we are in this low trust environment, and that makes it even more difficult to address and referee misleading claims that spread through communities. Okay, so what is driving hesitancy in 2026? Well, we're going to talk about some of the social and behavioral drivers. We're going to talk about the vaccine hesitancy continuum, and then we're going to talk a little bit about social media. Now, I like this framework from the WHO, and I know there are some updated frameworks, and there are a lot of different frameworks if you're in this field, but I like this because it's simple, and I like putting things in simple buckets. I'm a simple guy, I like simple buckets. It's not complicated. So there is a motivation, an intention to get vaccines, and that is influenced by multiple different things. Thinking, feeling, social processes, social norms, all of these things influence someone's intention to get vaccinated. However, even though I'm not going to talk about this today, in order to move from the intention to get vaccinated to vaccinated, there are a lot of practical issues to overcome. And this is the only slide I'm going to talk about this, but I want you to remember, do not ignore those practical issues. Everyone has a different level of intention to vaccinate, right? So because I love vaccines, I might be willing to drive over 2 mountain passes in the middle of winter storm and take a day off work because I have a job where I can do that and not lose it in order to get my kids vaccinated. But someone else, they may have the intent to get vaccinated, but they say, there's no possible way I can take off another day of work. I don't think I'm going to have a job if I take off another day of work. And look, keeping this roof over my kid's head is more important than getting their flu vaccine. Right. And so I just want us all to recognize that these practical issues, when you address these, that can overcome so many motivational factors to getting vaccinated. When you make it easier, it's a lot easier to just say yes. Okay, but what we're really focusing on today is what do we do when the vaccines are available? Okay, when they really are truly convenient and available. Well, I want to emphasize that vaccine hesitancy is a continuum. And at the bottom of this continuum, at the bottom of this pyramid, if you will, I really like this figure because the unquestioning acceptors who have no concerns, or the cautious acceptors who, maybe they have a question or two, but they're really they intend to get vaccinated. That's a majority of people still. That is a majority of parents. Okay, when you look at the data across multiple studies, multiple surveys, not only the vaccination data, but also intention and survey and poll data, what we find is that most people still want to vaccinate. Okay, and then you have a group that's much smaller who are concerned enough that they might decide to delay or selectively vaccinate. At the very top of the pyramid, you have people that refuse all vaccines. And what's incredible, and a lot of people don't realize, is that the percent of children who have never received a single vaccine remains incredibly small. Right around 1% of children have never received a vaccine. And it would be unfair to assume every one of those children who's never been vaccinated, it's all hesitancy. It is possible they face extreme access problems. So the take-home point is that most parents, most family members, most communities are still open to the idea of vaccinating. Even if they have a lot of hesitancy, there's something there. There's a thread that you can pull on. Now, there are a lot of reasons for vaccine hesitancy. I have talked in my career to parents about vaccines, I don't know, probably 10,000 plus times now. And each parent has a different specific reason for having concerns or questions about vaccines, but they tend to fall in the same roots of vaccine hesitancy. This is some work from colleagues over at the UK. I just like this model. They talk about two main roots being either fears and phobias or distrust. And I really do see this a lot in my clinical practice. So the fears and phobias can be anything from, I'm worried about side effects, to the chemicals in the vaccines, to vaccines cause autism, safety concerns, too many for the immune system. All of those fall into this fears and phobias about something with the vaccine. And then there is this group that has distrust. They either don't trust government, they don't trust healthcare, they're suspicious of people that either are producing, manufacturing, or recommending vaccines. Now, when you zoom in a little bit, there are some other roots that are a little bit more specific. Often there's distorted risk perception. We as human beings are not good at risk perception. We like to think that all of us are logical beings, and in fact, we are not purely logical beings. We do not always make decisions based on accurate risk perception. That's all of us. That's all of us, not just parents or your community. There's also this perceived self-interest, okay? So, I saw a lot of campaigns for vaccination really emphasizing, vaccinate your child to protect others. Well, a parent who has a priority of values that says, look, my child comes first, sometimes hears that and says, whoa, you're asking me to put my child at risk so that others can be safe. And if I see that risk as being extremely high, that's a big ask. We absolutely see the kind of defense of one's own freedoms to make decisions. And obviously, worldview and politics is coming into this more and more. Okay, so I would be remiss if I did not talk about the vaccine autism myth. And it is not the only reason that people are not getting the MMR vaccine. And in fact, Andrew Wakefield, in this article that I'll explain in a minute, was not the first one to recommend this idea. But I think this is a really good example of how a misleading claim, in this case, a fraudulent misleading claim, can be incredibly sticky and is around still today. So in 1998, Andrew Wakefield published this paper suggesting a relationship between the MMR vaccine and autism. Unfortunately, it took about 10 years to have this paper retracted, but it was eventually retracted. And this came on the heels of some incredible investigative journalism. And through this investigative journalism, several things came to light. Okay, first, this was a case series methodology. This was 12 cases. That is not the type of methodology that should be used to make any claim about causation. But this was more than just a poorly done study. Most cases were self-referrals from anti-vaccine groups. Several of the cases had symptoms of autism begin before they got the vaccine. And that was not disclosed in the paper. And then what makes this fraudulent is that Andrew Wakefield had applied for patents on a vaccine to rival the MMR vaccine and had received money to prove that the vaccine was dangerous. Since then, we have done dozens of studies across multiple different research groups, multiple different countries that have asked this question. Because look, I tell families, I say, if I give the MMR vaccine all the time, if I was causing autism in patients, I would want to know that. And vaccine delivery experts and pediatricians around the world would want to know that. So we've asked this question time and time again, and we have not found any link. But look, this is what parents are exposed to all the time. Whether they are looking for information about vaccines or whether they are just scrolling their social media feed, these questions pop up. Too many too soon. Vaccine ingredients, aluminum in vaccines, over and over and over again. And when they pop up, they don't have to share concrete evidence. They just have to scare the parents. So one of the common myths that we see is too many too soon. These next couple of slides, I'm going to show you some great materials from the Unbiased Science group, who I've had the opportunity to collaborate with on different messaging over the years. And they have created some great social media tools and graphics to help try to visualize for parents, help parents visualize the truth about some of these statements, right? So for the too many too soon myth, one of the reality is that compared to the vaccine schedule back in the 1980s, which had over 3,000 antigens, today's full schedule has just over 300. Now, this is mostly because we had the wholesale pertussis vaccine, which had quite a few antigens, but we've actually decreased the number of antigens in the childhood vaccine schedule. That's not something that a lot of parents are talking about. When the myth comes up about aluminum, which has been circulating for a very long time, when our own federal health agencies bring it up, it tends to get even more attention. These social media examples do a great job of explaining the reality that aluminum is all over our earth. It's in the food we eat, the water we drink, and the air we breathe. And it is actually in extremely tiny doses in vaccines, and children get more from breastfeeding, formula feeding, and eating, okay, than they will from the vaccines themselves. Regarding this myth about aluminum causing all sorts of conditions like autoimmune diseases and allergies and stuff, we have some good evidence now that there is no correlation. There is no evidence for a direct cause of aluminum leading to these things. Now, here's the problem. Correlation does not equal causation, but that's really hard for people to understand. So if you look at ice cream sales and shark attacks, there's a direct correlation. There's a direct correlation. Is that because when you buy ice cream, you're more likely to have a shark bite you? No, it's because on a nice day, like you're having, not like we're having in Colorado, on a nice day, you're going to get more people going out to the beach. You're going to get more people swimming in the water. You're also going to get more people eating ice cream. And so this is a hard concept for people to understand, but it's really important. Okay, so I think that what we've talked about so far is so important for you to understand because you have to start from a place of understanding what the parents in your community, what the community leaders and your clients and patients are exposed to right now. Because one of the most important things that I'm going to talk about in a minute you can do is really have empathy for people who are confused right now. And you can't have empathy for them if you don't understand just how confusing the information environment is. But what can we do about this? Well, look, here's what families and communities need right now. Okay, they are understandably confused. They're asking, what is recommended right now? We have seen the childhood schedule flip-flop several times. Unfortunately, we might see it flip-flop again, depending on how the court case continues to roll out at the federal level. They're asking, why are there these different recommendations? Okay, so the professional societies say this, this doctor says this person that says that. Why is there so many different recommendations? And the bottom line is they're just confused. And what they want from you is a trusted navigator who gives a clear recommendation, and they want reassurance that they can trust you. While trust in institutions is falling apart, trust in you is not. And here's the reality. Most families continue to vaccinate. They obviously remain one of the most effective ways to keep children healthy and thriving, and your recommendation still matters. This chart here I made for one of my Substack posts several weeks ago when there was an alarming headline from a poll that came out that essentially stated that most Americans were skeptical of vaccines now. Well, there were all sorts of problems with that poll. And if you want to learn more about that, I joined several podcasts to talk about the real serious methodologic problems with that poll. The reality is multiple polls from different organizations over the past year have really shown continued support for vaccines. Support for vaccines, support for vaccine requirements for schools, all of those things. So there is still a base of people that support vaccines. So remember, the first thing you do when people seem confused, concerned, and have questions is lead with empathy. I mean, example language for that can just be as simple as, I can see why this feels confusing. There are a lot of conflicting messages. Okay, start with that. But before I give you more tools on what to do, I want to carefully tell you what we know can backfire. Okay, so one of the things that can backfire is the fear appeal. This is a study that was done back in 2014, published back in 2014. And in this study, they randomized parents to receive one of four interventions. Either info explaining the lack of evidence that MMR causes autism, info about measles, mumps, and rubella from the vaccine information sheet, images of children who have measles, mumps, and rubella, or a dramatic narrative about a severe case of measles. Okay, and what they actually found was that none of those interventions increased intent to vaccinate, and they often backfired. In fact, refuting claims of an MMR autism link decreased the intent to vaccinate among parents who had the least favorable attitudes. Images of sick children increased a belief in vaccine autism. Now you might say, okay, this was 2014. So let's move to last month. So last month, there was a fantastic paper that was published on the new CDC language on their website about autism and vaccines. So if you remember, in November, they updated their website to suggest that the link between autism and vaccines had not been ruled out. Okay, this uncertainty-based statement. And researchers tested three conditions. They tested the old CDC website. Okay, they tested that clearly said there's no connection between autism and vaccines. They tested this new language, and then they tested no statement at all. Now, the expected finding from this was that uncertainty-based statements, the new one, reduced intention to vaccinate, okay, and increased the endorsement of science denial strategies. That's really not surprising. One of the findings that's underreported, and the authors talked about this, is that actually people that were exposed to both the old CDC website and the new CDC website had lower intention to vaccinate compared to not receiving anything. So this is important to recognize, that raising the question even to debunk it. Bringing this up when parents aren't necessarily concerned about it can sometimes activate doubt and backfire. So be careful with that. One of the other traps I see people get into is the data dump. What if we just give them more information, right? I mean, we have all this information, we know all of the information about the vaccine efficacy and side effects and risks and all of this. If we just give them this information, the light's going to come on and they will change their mind. And what we know is that this doesn't work, right? This is called the information deficit model. And that's not to say that there aren't people who have real knowledge gaps, okay? So if someone really doesn't understand why you're recommending the HPV vaccine to them, it's important to share that knowledge with them. But this assumption that if you just give them more facts, they're going to change their mind just doesn't work. Two other traps. The persuasion trap. This one can backfire. So this just assumes that decisions are simple decisions made on scientific logic alone, right? This assumes that the person across from you or the community you're talking to looked at the same set of facts that you did and they just simply came to a different conclusion, right? And this can actually harden hesitancy and communities can feel judged or dismissed when you are doing this. The other trap that's similar but slightly different is the debate trap. Look, vaccine conversations and talking to communities about vaccines, it's not a debate, okay? There is a place for the good faith debate about scientific facts. That is not what you're doing 99.9% of the time when you're talking to communities, okay? This triggers defensiveness and identity protection. They want to continue to identify with their community, their worldview, and so it's not a debate. What this brings us to is the reality that how we communicate about vaccines is just as important as what we communicate. The facts are absolutely necessary, but they are not sufficient. Okay, so I'm going to give you a simple model for face-to-face communication, and then I'm going to give you some simple tips for community communication. So when you are doing face-to-face communication, one of the most important things is that the person here's a clear recommendation that you do think this vaccine or these vaccines are important for their health or their child's health, and that you initiate it with the assumption that they're probably interested in vaccinating. Okay, this is easy. All you do is say something like, hey, I recommend this vaccine to everyone. And have you gotten your flu shot this year? Oh, looks like you're due for it. It is simply announcing what they're due for. When that happens, you'll typically see one of three responses. You will either have someone say, okay, because they wanted to get vaccinated, right? And they're on board with it. Sometimes you will see people who are hesitant right out of the gate. And they say, I don't think I want to do that. I've thought about this. I don't want to do that vaccine. Or you'll see people have a question. Now, one of the important things to recognize is that when people have a question, first, just address the question specifically. One of the things I see, one of the traps people get into is assuming if someone has a question, they have concerns, is assuming that they're hesitant. It is normal as a parent or as anyone to have questions or concerns about something like a vaccine. So answer them with short, digestible, easy to understand answers, and then gauge where they're at. Because frequently when you answer their question, they'll say, okay, great, thanks. Yeah, sure, let's vaccinate. Sometimes it becomes clear that even after you've answered their question, they are hesitant. And that is when we pivot into using motivational interviewing. Now, look, I don't have time to teach you all motivational interviewing today. So the skills I'm going to tell you on the next two slides are like playing Happy Birthday on the piano. That I think you can learn. And motivational interviewing is in the spirit of partnership, acceptance, compassion and empathy, and evocation or elicitation. There are 5 skills that we teach. Many of you probably already use some of these. One is just simply asking open-ended questions. So after someone says, no, we don't want to do the MMR vaccine, saying something like, okay, I'm really curious. Would you mind telling me why you want to wait on the MMR vaccine? Simple, open-ended question, curiosity. Affirmation is the next skill. It is clear you want to do what's best for your health, or it's clear that you want what's best for your child's health. You don't need to affirm a misleading claim or a myth. Affirm that they care about their health or their child's health. Reflection is the next skill. It sounds like you are most concerned about whatever it is. The next skill is autonomy support. Ultimately, this is your decision to make. I can't tell you how important this skill is, especially if you feel the temperature of the conversation rising, because ultimately it is their decision to make, and saying that out loud can really help lower the temperature. Finally, I don't see this one used nearly enough, asking permission to share. So before you share a little bit of information, data, facts, or why you recommend a vaccine, say something like, would it be okay if I share with you why I recommend these? A spin on several of these that I think is so valuable, one, is asking what benefits they see to vaccines. Okay, so instead of asking, why are you concerned over and over again? Tell me more about your concerns. Ask, hey, I'm really curious. Do you see any benefits to vaccines? That forces them to consider that there might be benefits. It is okay to hear out negative emotions and negative motivations. You don't necessarily need to refute every single statement that a person makes. Again, this is not a debate. Look for opportunities to refocus the conversation on the benefits and the patient's own positive feelings, and promote this change talk, remembering that most people are at least a little bit open to the idea of vaccinating. So here's what this could look like. A patient might say, I've seen a lot about the MMR vaccine and how it causes autism. I'm not sure I want my child to get it. If you fall into the trap, you might say something like, actually, that's wrong. The CDC changed their website recently for political reasons, and you can't trust them or anything you see on social media. Measles is bad, and it can kill your child. You might be laughing right now, but I have seen this. I have seen this many times, okay? Try this instead. It makes sense that you would have questions. There's a lot of confusing information out there, and you want to make sure this is safe. Can I share with you what we know about where that concern came from? And often the parent or the patient or whoever it was will say, sure, you can tell me more. If you, again, fall into a trap, you might say something like, you can't believe everything you see. It all started in 1998 when Andrew Wakefield published an article in a journal called The Lancet. And then 10 minutes later, I mean, it's like, wah, 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 wah. The patient or community member, they're not listening to you, right? Instead, in a digestible way, you could say something like, MMR is one of the most studied vaccines we have. Millions of children across dozens of countries. The concern originated from a single fraudulent study that was retracted. The science here is unusually clear. Right? Just really simple and concrete. Okay, so briefly, communicating with communities. So let's step beyond the face-to-face interaction. Now, face-to-face might involve multiple people, but when I talk about communicating with communities, I'm saying this is often somewhat asynchronous and often a little bit more of mass communication, okay? Now, I do think even when you're communicating with communities, you need to get feedback on your messages, and it is two-way, but it's not in the same conversation style that I just described. So you've got two modes and two toolboxes. I just described individual communication, okay? One-on-one, where you have a relationship, you might be trying to recommend a vaccine at that visit, and the trust is very personal. Public communication involves many people at once, and you're talking about community level confidence. Now, the tools that work better here are things like narrative over data and facts, trusted community messengers, the messages coming from community messengers. I'm going to talk briefly about pre-bunking and media engagement as well. And the speed and framing in the community messaging really matters. People share stories way more than they share statistics in communities. So lead with a narrative and then back up with the evidence. And look, you can actually get better at this. Okay, this is a publication in the New England Journal of Medicine by some wonderful friends and colleagues who really called for this. Look, scientists, doctors, public health professionals, all of you, you need to become effective communicators beyond your own little circles. And that does not mean every single one of you needs to be on social media. That does not mean every single one of you needs to be willing to go on CNN or go on a podcast, because that just might not be your style, but you can still be an effective communicator in your communities. And this means meeting people where they are, okay? And connecting with their values. So many communities prioritize, and cultures prioritize face-to-face conversations and meaningful connections over efficiency and social media posts. Take time to build trust without rushing, refraining from judgment, and meeting people where they are. this can strengthen the relationship so much with communities. Also, you have to learn about your community. Invest time in understanding who you are serving. Where do they come from? What religions are practiced? What different aspects about their community? This does not mean that you are going to be the expert in their community, but you need to learn about your community enough that you can communicate more effectively, that you can find the trusted messengers, that you can build relationships with them in their community. And I want to talk specifically about religious vaccine hesitancy. For many reasons. I know that you experience a lot of this in Maine, and we see a lot of this across the country, but here's what I want to say about this. It is not monolithic. There are many different religious beliefs, and the religious beliefs, even within, let's say, the Christian, broader Christian tent, there are varying reasons for hesitancy. So among kind of the Anabaptist, Amish, and Mennonite communities, often there is more of a communal decision-making and a little bit of a distrust of outside systems and health and things like that. However, they are very close-knit and a very high outbreak risk when immunity drops. Okay, some evangelical Christians will have more of a concern around bodily sovereignty. They may be skeptical of government mandates, believe more in the natural immunity type of things. And so these are just examples of how, look, you cannot assume, do not make assumptions about a religious community and why they are hesitant. That's why it's important to work with faith leaders. Okay, so the working with a trusted religious leader carries way more weight than any public health flyer. Identify leaders who are already open to the conversation. Offer to come to them, offer to talk to them. Don't force them to come into your setting, into your playing ground. Provide simple talking points that they can use with their community. Offer in community or in church clinics, remove access barriers, and all of these things. So there are multiple examples of this working well. Okay, we saw this actually work very well and I've heard this from so many wonderful colleagues in Black churches during COVID vaccination. I'm going to share two examples where this worked well in my own experience. I practiced in Montana for several years, very close to an Anabaptist community. Okay, so Anabaptist, this is a wonderful community called the Hutterites, and they're similar in some ways to Amish and Mennonite communities. Well, you know, I really found that when I developed trusted relationships with these families, they were very open to vaccinating, but they typically weren't open on the first time that they met me, right? They would see me in clinic, and it was over several clinic conversations. It was when I ran into them at the farmer's market and they were selling their incredible produce and talked to them. It's after those interactions that they said, hey, we're going to do these. And they decided to vaccinate not because they learned new information. I asked why they decided to vaccinate, and they said, because we trust you now. Right, so it's building that trust that matters. I had the opportunity to serve this beautiful Somali community in Seattle when I was in residency, who none of them wanted any vaccines. They came in and they said, we do not want any vaccines. And when we asked and really explored why, it was because their religious leader, their imam, had said no to vaccines. This is not work that I did, but some of my colleagues did incredible work with this religious leader, building trusted relationship, and came to kind of find out that they just had a misperception about vaccine risks. When this religious leader learned that it was a misconception, we had the Somali community flood into clinics asking for vaccines because the religious leader said, yeah, you can get your children vaccinated, right? No amount of facts, no amount of pamphlets or handouts or education would have changed their mind because it was a part of their community identity and their religious identity. It took working with their religious leaders to really make a difference. Okay, finally, I've got 2 more slides left, but I want to talk about this. Now, this is a little bit of transition to something called prebunking. So just like vaccines build immunity to disease, there is this concept of psychological inoculation, which I don't love the term. It sounds kind of science fiction-y and kind of maybe it sounds scary to people, but prebunking is maybe a better term. But this is building immunity to misinformation. This is exposing people to common tactics on manipulation, not the myth itself. But here is how you are being manipulated by the social media posts. Okay, so you can actually teach patients in your community how falsehoods spread and how to pause and spot them. This is a handout that I led the American Academy of Pediatrics and Center for Unbiased Science and Health. We made this in collaboration, and I'll show you the back side of it in a minute, but it's a very simple handout for families that just simply says, whoa, everything you see might not be as it seems, and here is a simple checklist. Simple checklist. When you see something, ask yourself, am I being offered something that seems way too simple to fix with a complex, that's actually a complex problem? Is this trying to scare me? Is timing proof of causation, right? Like there's no other evidence other than, well, I don't know, these two things happened in the same year, so they must be connected, right? Family members and community members can go through this, pause briefly and just say, wait, who is maybe making money off of this? There's a link at the bottom of this to some supplements. I wonder if they're just trying to make money. Okay, so prebunking and teaching people how to spot misleading claims is so important. I mean, I think we probably need this in our education system from a young age anymore now. Okay, I've shared a lot today, and I want to end on resources. This is not a complete list of resources. There are many more. And I don't want people who maybe have worked with other organizations to be disappointed. They're not on this page right here. I couldn't fit everyone, but I want to just point out several things. When it comes to vaccine clinical guidance, the professional societies, the American Academy of Pediatrics, the AFP, ACOG, et cetera, they are one of the best places to go right now with the void in federal vaccine guidance. Okay, other great guidance is coming out from immunize.org, the Infectious Disease Society of America, and the National Foundation for Infectious Diseases, or NFID. For patients, and I have students on here, but for patients and community members and people that want a little bit more information, I love places like the CHOPS Vaccine Education Center. They're doing incredible work and sharing really good information. Voices for Vaccines and Vaccinate Your Family, also incredible information in a format that's a little bit more accessible to some people that want narrative and story. Obviously, the AAP, again, healthychildren.org is where I send a lot of people, and especially families and parents. And then if you want to stay current, I would recommend following what CIDRAP is doing at the University of Minnesota and the Vaccine Integrity Project there. They're doing incredible stuff. The Evidence Collective and Unbiased Science, who I have collaborated with over the years and continue to, is partnering with them as well to try and put out good real-time information. And of course, you also can follow me on my Substack. I get a little bit more in the essay realm of things and don't necessarily put on a lot of practical stuff through that method, but I would love for you to follow me. So here are the other ways that you can follow me as well. And I am happy to take questions.
That was fantastic, by the way, David. That was absolutely packed with information that was very, very, very useful. So thank you. I also did put links to your Substack, your website, your X account, LinkedIn, and everything in the chat as well. So Amy Belisle, who is our works at the state and Maine DHHS and is a pediatrician as well and an MPH, and she's a chief, I forget what your title is, Amy, but Chief Pediatric Officer for the state or something like that. But anyway, Amy, you've got a question.
Yeah.
Thank you.
Thank you. Great talk. So where do you see us going in the next couple of years with everything happening at the federal level? And what in terms of messaging, and what can we do at the state?
Yeah, such an important question. And one of the things that I'm exploring right now in my Substack and in some work with the Evidence Collective is where do we go from here? Not fully understanding what's going to happen at the federal level over the next couple of years. And I'm reminding people that, look, we're not going to go back overnight to how things were in 2024. It's not possible to go back overnight. And even if we did, not everything we were doing there worked perfectly either. So what I think we're really seeing, I think what we need to emphasize and do is the states, the communities, local public health, healthcare organizations across states, especially that have big geographic reach, you need to be involved in good community messaging. The Recommendations for vaccines are still at this point going to be fractured. Fortunately, the American Academy of Pediatrics has really stepped up to the plate in offering clear recommendations. Some of the adult recommendations are a little bit more unclear and fractured right now. I think that's going to be the norm for the foreseeable future. I'm not sure we're going to have federal level recommendations that we're going to be able to get behind. So it is your both privilege and responsibility at the state level to be a communicator, because people in your state, people in your communities, they trust you. They might not trust the CDC. They might not even trust the American Academy of Pediatrics. Okay. But they trust you. You are in their communities. Okay. They see your name, they see your information. So you need to be sharing that messaging out. And I also really emphasize you need to be working with community messengers. You need to be identifying those people in communities that can be messengers. They don't have to be the scientist. They don't have to be a vaccine expert. They don't have to be any of these things. They just have to be leaders in your communities who are willing to pass along simple messages about the importance of vaccines, about where people can find good, reliable information about vaccines. And nobody's better suited to do that than you, because you know your state and you know your communities.
Thank you. And Kathy Burgoyne, who is also an MD MPH, is joining us too for a question. Thank you, Kathy.
Hi, I'm a family doctor from Maine, and throughout my career of like 30 years, I'm retired now. I would often tell the story of when I had the measles when I was 7 and there was no shot, and how sick I was. And they usually say, "Oh, I thought it was just a rash and a fever. You were really sick," and blah blah blah. And also, I would tell them if it was pertussis they were concerned about. I would explain how I was up with a baby for 36 hours, and I would make the coughing sound that they made and stuff. And I never had anyone refuse vaccines. I think a lot of the doctors and nurse practitioners and et cetera these days have never seen these diseases. And they really, can't explain as well as we can what it was like and how awful it was. And so I think that is, hard. I did go on Blue Sky, and as I post things on there sometimes, and put on my personal experience with measles and an audio of a child with pertussis and explaining those things. And I got a lot of positive responses to those. That people just didn't really know,
Yeah, so I love that you brought this up, because one of the things when I talk about the fear appeal not always being successful, I want to make really clear that personal narrative and personal experience matters. So I share frequently that I, in residency, had a baby with pertussis die right in front of me, despite our best efforts. And I mean,
and meningitis, I saw babies die from that.
Yeah. And I saw a child with tetanus that was in the ICU for 6 weeks and had to get a tracheotomy because they couldn't breathe right in front of me. And those were traumatizing experiences for me as a physician.
Oh, yeah.
I still remember those. And when I share that personal story with families, it does make a difference. So, but it's not abstract, right? It's not, oh, well, because sometimes our fear appeal is abstract. It's, look, you should be scared of measles for these reasons. But when it's a personal story, like you shared, of children you've treated with meningitis or pertussis or hospitalized for measles or whatever it was, that goes a lot further. So I love that you shared that.
I was in bed for 10 days in the dark with a fever of 105, and I saw the little characters from Get Smart crawling up my quilt. They'll remember that.
Right. That's something that stays with you the rest of your life. And I do think it's important to use that personal narrative.
The other quick thing I want to mention was I was in Nova Scotia, Canada, and the head of pediatrics up there was presenting on vaccinations. And he said if the children didn't come in for their vaccinations, they sent MAs to their home to vaccinate them. And when I was there 15 years ago, they had a 98% vaccination rate, and they were disappointed by that. So I just wonder, couldn't we do that here? I mean, a lot of people probably want to get vaccinated, they just can't get it.
Oh, absolutely. And one of the things I talk about frequently is people assume if a community is not vaccinated that they just don't want them. And that is a dangerous assumption to make, right? It is a dangerous assumption. And I have seen that in my own experience with communities where people assume, well, this community they just must be hesitant. And then there's an outreach clinic and they're lining up for vaccines, right? It's at a school, it's at a church, and they're lining up for vaccines. So I love that you brought that up. It can be a dangerous assumption to simply say, well, this community's vaccination rate is low. It's because they're all hesitant or because they're all politically affiliated with someone. Do not make those assumptions. Go in, learn the community, get engaged with the community, bring vaccines to them, and I think you could be surprised.
Sounds like it's
Thank
really
you.
about relationships, isn't it? It's community
It is.
relationships with the patients and their families. And now you've really brought that to light, and particularly with a number of wonderful, pragmatic strategies too. So, and some scripting. So thank you again so much. We're at the end of our hour. That went so fast. And we've had a lot of comments in the, we had about 70 people on and at the height, and none of them had to leave because of the end of the hour, but lots and lots of comments thanking you in the chat there for your time, and what a great presentation they've also said.
No,
So,
thank you so much. It was a
I
pleasure to be
agree.
with you all today.
Thank you very much, David. It's great to see you. And we'll see you sometime in person. Hopefully come on out to Maine with your family and visit.
I would love it. I would love it. Thank you all.
Take care. Bye-bye.
Bye-bye.
Bye-bye, everybody.